In this video, we are going to discuss the tumor markers, especially the laboratory use of the tumor markers or diagnostic use of tumor markers. Now, let's see what are the tumor markers and why we are going to use the tumor markers, what the tumor markers should do for us. Relatively, the tumor markers are the biochemical indicators of the malignant tumor. These kind of substances, biological substances that synthesized and released by the cancer cells or produced by the host in response to presence of the tumor. So relatively, anything can be tumor markers that is directly correlated with the presence of the tumor cells, so the tumors in our body. The appearance or change in the concentration indicates tumor or change of its mass. These tumor markers can be intracellular or surface antigen that can be detected as histochemical reactions, or extracellularly that's excreted into the blood fluid, and this way the clinical chemical detection is good. For example, Oncofetal antigens, carbonhydrate glycoprotein antigens, enzyme hormones, and other proteins can be tumor markers. Now, indication of the use of the tumor markers in the clinical practice. First of all, we want to screen population that are at risk. However, not all tumor markers are good screening tools, or I would say maybe only one that can be used for screening. Diagnosis. Use results from markers, but imaging, risk factors, and other symptoms usually together can make for the diagnosis. Prognosis. The concentration of the markers determines the prognosis of the diseases or detection of recurrence. Once tumor is removed, elevation of the marker can indicate regrowth of the tumor cells. Or monitoring the response to treatment. Decreased level of the tumor markers indicate the therapy is working. An increased level of the tumor markers may indicate need for change the therapy. These are some response or some treatment effect on the CEA, the chorioembryonic antigen, in remission when the tumor markers level stays very low. Or we can have a local recurrence when the tumor is growing back, but only a low amount, so possible only the local area or recurrence occurring the tumor. When we do have metastasis, the tumor markers level usually tremendously increased. Or progression, when we do have a progression in time, it increases, but never reaches as high as the metastasis. What could be the ideal tumor markers? I would say that there is no ideal tumor markers, but we can talk about it. The tumor marker should be specific and selective to the certain tumor that we are testing with. The level of the tumor marker should change in response to the tumor size. So if you do have a bigger tumor, the size bigger, so the level of the tumor marker should be increased. If you have a smaller tumor, the number should be smaller one. An abnormal level should be obtained in the presence of the micrometastasis. It should be very, very sensitive one. The level should not have large fluctuations that are independent of changes in tumor size. Levels in healthy individuals are at much lower concentration than those found in cancer patients. So that should be very specific and selective one. Predict recurrence before they are clinically detectable. So we should know, let's say, the regrowth of the tumor before the clinical symptoms occurs. And of course it should be cheap, so it could be cost effective. But as I said, none of the marker can fulfill the all categories that I mentioned here. Let's see the first important quality of the tumor markers, and that's the sensitivity and the specificity. It's not the same. Sensitivity in the rock diagram usually meaning that taking the positive patients out of the patient with tumor, how many of the patients with tumor can be picked Of course, if you do have 100% sensitivity, this meaning that you are going to pick up every patient out of this group. Specificity. How specific this marker? Usually, we are taking the negative results. So the patient without any kind of tumor, a homogeneous population without tumor, how many is detected as negative? So if you do have 100% specificity, it's meaning that you picked up everybody from the group. Of course, these two is depending on each other, because if you have a very sensitive marker, so if you change the sensitivity, relatively the specificity is lost. So this is why if you are, for example, look at here, this is a rock diagram of chorioembryonic antigen. The specificity is going to increase by the concentration. So if you go for a very high concentration of Ca, for sure those patients who had this kind of tumor with positivity Ca has tumor, and none of them has, let's see, healthy. However, if you are going another way, if you are getting a less and less and less state, you see that the sensitivity is going to increase. So it's meaning that you are picking up everybody. However, you are picking up more person from the healthy group as well. For sure, this curve, when it's crossing each other, that's be the ideal point. And you will see that how this common specificity sensitivity or how the clinical usage can be. For example, in the CEA, in this case, what we do have, or chorioembryonic antigen is 192, that could be the concentration 192, when if you have above that, for example, for sure tumor, if it's less, it's maybe is not. So the sensitivity, it can be around 80% or so. What kind of tumor markers we can have? As I mentioned, anything can be a tumor marker, but we can categorize. It can be, for example, Oncofetal antigens that usually in the fetal life was active but after it was suppressed, and these kind of genes are released, and again it synthesizes this kind of protein antigens. Hormones such as HCG, calcitonin, serotonin, catecholamine, and so on. Enzymes or isoenzymes such as alkaline phosphatase or carbonhydrate epitope recognized by monoclonal antibodies such as the CA15-3 or CA19-9, or receptors such as estrogen or progesterone receptors, or genetic changes, mutation in some oncogenes and tumor suppressor genes. Some mutation, for example, in the breast cancer type 1 susceptibility protein or 2 are linked to the hereditary breast or ovarian cancers. These kind of genes are important in the DNA repairing mechanism and relatively cleaning those cells that they are affected. Let's look at first the Oncofetal antigens. The most common one and the most used one is a carcinoembryonic antigen. This is a cell surface glycoprotein antigen produced during the embryonic development. Elevated in adult one usually can mean colorectal, breast, GI, liver, lung, and pancreatic cancer. CA testing should not be used for screening. Some tumors don't produce CA. It is useful for staging and monitoring therapy. Be aware that false positivity can occur in smokers, patients or with liver cirrhosis or inflammatory disease of the GI tract. Alpha-fetoprotein. Alpha-fetoprotein is the most abundant plasma glycoprotein found in the human fetus, produced by the yolk and later on in the fetal liver. Alpha-fetoprotein in adults can indicate a hepatocellular carcinoma or germ cell tumor and metastatic carcinoma of the liver. Alpha-fetoprotein is measured in pregnant women throughout the analysis of the maternal blood or amniotic fluid, a screening test, for example, for an increase in the open neural tube defects and omphalocalia, and decreased level could be seen in Down syndrome. Elevated level can be found in twin pregnancies as well. Hormone markers such as the HCG, the human chorionic gonadotropin level, that's a siloglycoprotein produced by the placenta. Most commonly, it is used as a pregnancy test. Testing for the HCG may also be done when diagnosing or monitoring germ cell tumor and gestational trophoblastic diseases. The beta HCG can be positive in testicular teratoma. HCG doesn't cross the blood-brain barrier. High level of the cerebrospinal fluid may indicate metastasis to the brain. Calcitonin. That is positive in medullary thyroid carcinoma, but also increased in mammal carcinoma. Calcitonin levels should be high in some patients, for example with cancer of lung, breast, kidney, liver, and in non-malignant conditions such as the pulmonary diseases, pancreatitis, hyperthyroidism, myeloproliferative disorders, and pregnancy. The serotonin or 5-hydroxyindolic acid, the positive in epidermis and carcinoid syndrome, or catecholamides and derivatives, for example, positive in pheochromocytoma and neuroblastoma. Enzyme, alkaline phosphatase, that's an obstructive enzyme. However, it can serve the tumor marker. For example, in liver cancer, or its level may be helpful evaluating metastatic cancer in a bone because osteoblast contains alkaline phosphatase or liver involvement. Placenta is another rich source of alkaline phosphatase, and again isoenzyme elevates in a variety of the malignancies, including ovarian, lung, gastrointestinal cancer, and Hodgkin's disease. Prostatic acidic phosphatase. It is used for staging prostate cancer and for monitoring therapy. Increased prostatic acidic phosphatase activity may be seen in osteogenic sarcoma, multiple myeloma, and bone metastases of other cancers, and in some benign conditions such as the osteoporosis and hyperparathyroidism. Neuron-specific enolase, one of the glycolytic enzyme, neuroendocrine originated cells secretes with high quantity. Tumor markers for neuroblastoma and small cell carcinomas. Other tumors, we mentioned the prostate-specific antigen. That's a glycoprotein with serine protease activity produced by the epithelial cells of prostate. Now, this PSA can be used for screening. This has a higher specificity and selectivity. Concentration of serum is elevated in prostatic hypertrophy and prostatic cancer. PSA testing itself is not effective to detecting early prostate cancer. Other prostatic disease, urinary bladder catheterization, and digital rectal evaluation may lead to increase the PSA level in the serum. Most PSA in the blood is bound to the serum protein. A small amount is not protein bound is called a free PSA. In men with prostatic cancer, the ratio of the free, the unbound PSA to the total PSA is decreased. So the risk of cancer increase if the free to total ratio is less than 25%. The serum level of the PSA was found to be correlated with the clinical stage, grade, and metastasis. The greatest clinical use of the PSA in the monitoring of the treatment. This may require 2 to 3 weeks. If it's still at high level after 2 to 3 weeks, it must be assumed that residual tumor is present. Androgen deprivation therapy may have direct effect on the PSA level that is independent of the anti-tumor effect. Carbonhydrate markers. These markers either are antigens on the tumor cell surface or are secreted by tumor cells. They are high molecular weight mucins or blood group antigens. Monoclonal antibodies have been developed against these antigens. Most reliable markers in this group are the CA15-3, CA125, and CA19-9. The CA15-3 is a marker for breast carcinoma. The elevated levels are also found in patients with pancreatic, lung, ovarian, colorectal, and liver cancer and in some benign breast and liver diseases. It is not useful for diagnosis. It's most useful for monitoring the therapy. Although CA125 is a marker for ovarian and endometrial carcinomas, it is not specific. The CA125 elevates in pancreatic, lung, breast, colorectal, and gastrointestinal cancer and in benign conditions such as cirrhosis, hepatitis, endometriosis, pericarditis, and early pregnancy. It is useful to detecting residual disease in cancer patients following initial therapy. It is also useful in differentiating benign from malignant disease in patients with ovarian masses. The CA19-9 is a marker for both colorectal and pancreatic carcinoma. However, elevated levels were seen in patients with hepatobiliary, gastric, hepatocellular, and breast cancer, and in benign conditions such as the pancreatitis and benign gastrointestinal diseases. The CA19-9 level correlates with the pancreatic cancer staging. It is useful in monitoring pancreatic and colorectal cancer. Elevated levels can indicate recurrence before detected by the radiography or clinical findings in pancreatic and colorectal carcinoma. Protein markers. The most reliable markers in these groups are the beta-2 microglobulin, ferritin, thyroglobulin, and immunoglobulin. We were talking about in the previous lecture about when we're talking about the proteins, the beta-2 microglobulin that is used to evaluate the GFR and the tubular function. Beta-2 microglobulin is a marker for multiple myeloma, the Hodgkin lymphomas. It also increases in chronic inflammation and viral hepatitis. The ferritin is a marker of Hodgkin lymphomas, leukemias, liver and lung and breast cancer. Thyroglobulin is a useful marker for detecting and differentiating thyroid cancer. Immunoglobulin. The monoclonal immunoglobulin has been used as a marker for multiple myeloma for more than 100 years. Monoclonal paraproteins appear as sharp bands in the globulin area of the serum protein electrophoresis. Benz-Jones protein is a free monoclonal immunoglobulin of the light chain in the urine and is a reliable marker for multiple myeloma, but only 20% of the patient has Benz-Jones protein. Usually they do have a kidney damage later on. Amyloidosis can happen. Other tumor markers such as a TPA or tissue polypeptide antigen, that's a universal tumor-associated antigen which is regarded as a marker of the cell proliferation. The marked elevation of the serum TPA is reported in a variety of the cancers such as the breast, lung, gastrointestinal, urological, gynecological cancer. TPA is known to be sensitive but not specific tumor marker. So to follow the therapy or the regrow, it's very good one. The CIFRA 21-1, it's used as a tumor marker for a non-small cell lung carcinoma, such as a squamosal cell carcinoma, adenocarcinoma, and large cell carcinomas. S100 protein that the family are useful as markers for certain tumors and epidermal differentiation. Serum level is elevated in neurinoma, glioblastoma, astrocytoma, meningioma, and melanoma. Receptor markers, that's estrogen and progesterone receptors, are used in breast cancer as indicators for hormonal therapy. Patients with positive estrogen and progesterone receptors tend to be responsive to hormonal treatment. Those with negative receptors will be treated by other therapy. The hormone receptors also serve as a prognostic factor in breast cancer. Patients with positive receptor level tend to survive longer. Cytoplasmic estrogen receptors are now routinely measured in samples of the breast tissue after surgical removal of the tumor. Of patients with breast cancer, 60% have tumors with estrogen receptors. Approximately 2/3 of the patients with estrogen receptor positivity tumors respond to the hormonal therapy. 5% of the patients with estrogen receptor negativity tumors respond to the hormonal therapy only. Progesterone receptor testing is a useful adjunct to estrogen receptor testing because progesterone receptor synthesis appears to be dependent on estrogen action. Measurement of progesterone receptor provide a confirmation that all the steps of estrogen action are intact. Breast cancer patients with both progesterone and estrogen receptor positive tumor have a higher response rate to hormonal therapy. CERP2 or HERP2 knew that the protoantigen of the epidermal growth factor 2 receptor family of receptor tyrosine kinase used to evaluate the progression progression of the human breast cancer. Genetic stages. 4 classes of the genes are implicated in the development of cancer, such as the proto-oncogenes, which are responsible for normal cell growth and differentiation. KRAS and RAS mutation are found to be correlated with acute myeloid leukemias and neuroblastomas. Tumor suppression genes. Alteration on these genes may lead tumor development, such as the retinoblastoma genes, p53 genes, p21 genes. Those genetic markers are very new and not routinely measured in the laboratories, but future it be more used. Apoptosis-related genes are responsible for regulation of apoptosis. BCR2, for example. DNA repair genes, which are involved in the recognition and repair of the damaged DNA. That is a BRCA1 and BRCA2 that I mentioned before are specific genes in an inherited predisposition for development of breast and ovarian cancer. Mismatch repair genes are mutated in some colon cancer. These tables are summarizing the tumor markers that usually used in an orchestrated way, for example, to check colorectal carcinomas, together TPA, CEA or CA19-9, germ cell tumor. And this way, if you apply these tumor markers in an orchestrated way, the more the specificity, sensitivity, they are going to increase. What are the use and how do we assess, let's see, the markers? Basically, before the surgery is done, this is definition of the relevant tumor markers for follow-up. This is when we're taking samples, how low the tumor markers level after the treatment. After surgery, we assess the success of the surgery. This takes 2 to 4 weeks after the surgery. After that, the monitoring of the adjuvant therapy modalities, for example, before initiation of the therapy, every 3 months during the first and the second year, and after every 6 months during the third year to the 5th year. Monitoring of palliative therapy modalities, for example, before the start change of therapy, and after every 2 months. This is how we are going to follow the patients. Now let's see, for example, a tumor marker monitoring what happened. There's a 44-year-old patient with melanoma, and what they do a immunotherapy, and for a long time, after months, looks like they started to increase. Now, the CT progression was confirmed, and after they changed to cytotoxic therapy. The cytotoxic therapy didn't work too much, and the progression was, confirmed by the CT, and immunotherapy came into the picture again, and now we do have this plateau phase. But after, when the immunotherapy didn't work, the patient, the tumor markers level was increased linearly or exponentially, and the patient died.